Educación universitaria, María Cano.
Amputation. It is a condition of permanent nature that, if the necessary rehabilitation actions are not taken, will constitute a cause of severe impediment in the performance of daily work and recreational activities, as well as in the social participation of the people who acquire it. According to the classification of the American Academy of Orthopedic Surgeons, amputations through the thigh and leg are referred to as transfemoral and transtibial, respectively. Amputations performed through the knee and ankle joints are called knee and ankle disarticulation, respectively. It is a surgical procedure that consists of the removal, extirpation, or resection of part or all of a limb through one or more bone structures in a perpendicular manner to the longitudinal axis of the limb. The most common causes of amputation are diabetic or non-diabetic vasculopathies, severe traumas, tumors, neuropathic diseases, thermal injuries due to heat or cold, infections, and congenital deformities. The usual amputation levels are upper limb, fingers, partial hand, wrist disarticulation, transradial, elbow disarticulation, supracondylar, humeral neck, shoulder disarticulation, and interscapular thoracic. Lower limb, toes, partial foot, cymes or ankle disarticulation, transtibial, knee disarticulation, transfemoral, hip disarticulation, and hemipelvectomy. Possible complications of amputation: hematomas, minimized with hemostasis and Penrose drains. Infections. They are much more frequent in amputations due to peripheral vascular disease, especially in diabetic patients. Necrosis. Mild necrosis can be treated conservatively. More severe necrosis requires wedge resection or proximal reamputation. Contractures. They should be avoided through proper positioning of the stump and exercises to strengthen muscles and mobilize joints. Neuromas. They always form at the end of a severed limb. Pain caused by a neuroma is usually due to the traction exerted on a nerve when scar tissue pulls on it. They can usually be avoided by cleanly sectioning the nerves at a proximal level so that they rest in normal soft tissues. Phantom limb sensation. After almost any amputation, the patient has the sensation that the amputated part still exists. They should undergo psychological evaluation. Other complications: stump degeneration, circulatory disorders, skin disorders, wound dehiscence or opening. Recommendations: if the amputation is below the knee, the stump should be kept in complete extension. Do not place pillows or blankets under the knee. A firm mattress that does not allow it to sink is recommended, so the hip will not be flexed and neither will the stump. After the wound heals, keep it uncovered. Wash the stump every day with water and mild or neutral soap and dry it well. Use the elastic bandage all the time. Wrap it again every 2 or 4 hours and check that it has no folds. The way to wrap it is diagonally, never in a circular way. When standing, do not allow the residual limb to be raised. This in order to avoid postural defects that may interfere with subsequent prosthetic management. Once the wound is closed and the stitches are removed, 10 to 15 days, scar management begins to avoid adhesion. A gentle massage will be performed in a circular direction and in the form of a zebra, applying pressure according to your tolerance. Massage will be performed on the stump to help the conformation of it and facilitate circulation. The most used technique is netting. Desensitize the stump by gentle massaging it in a circular and zebra-like motion. You can also use various textures, starting with soft things, a damp towel, or a fine bristle brush. Rub the scar and stomp gently with a piece of soft thread or cotton cloth, progressing to a dry towel and a brush with stiffer bristles according to your tolerance.